Okay, thank you, Peter, for that introduction and for inviting me to be the first masterclass in this session. So as Peter introduced, I'll be talking about the outbreak management unit that's taught as part of our graduate certificate of health protection, but is also an elective in the advanced practice suite of units. My presentation today will be going through how we do conduct an outbreak investigation. So answering that question, ever wondered how public health units find out about outbreaks and then figure out what caused them. So I will walk through the 10 steps of an outbreak investigation, introduce what each step contains, and then run through an example from a real-life outbreak that occurred in New South Wales. With regards to questions, if you have any throughout, please either pop them in the chat or use the Q&A button, and I'll answer them at the end of the presentation. I'm also going to ask throughout my presentation for you guys to answer some polls. I'll pop them up at the appropriate time, and I'll also ask you some questions for which you can put the answers into the chat. Okay, so moving on to the 10 steps of an outbreak investigation. The first step is obviously to detect an outbreak, so to actually find out about a potential outbreak. And there are two main ways that we find out about an outbreak. The first one is by monitoring our surveillance data and seeing if there are any increases in notifications. So in Australia and many countries, we have indicator-based surveillance systems, where in Australia, I think it's about between 60 and 80, depending on what jurisdiction you're in, diseases are mandated to be reported to the health department. At the health department, these diseases are monitored, and as you can see here in the figure, if there is any increase, they're then investigated as a potential outbreak. The second way that we find out about outbreaks, and this usually happens at about 4:30 on a Friday afternoon, is we receive a phone call from somebody reporting a potential outbreak. This phone call or email may be from a doctor or a laboratory reporting an increase in cases in their facility, or it could be a member of the public ringing up saying, you know, friends of ours went out for dinner the other night and now several of us are sick. And as I said, these do often happen last minute Friday evening, so you then have to spend your weekend investigating a potential outbreak. Okay, so this is the example that I'm going to work through today. So you're working at the PHU, the Public Health Unit, and you had received a phone call yesterday morning from a doctor in an emergency department. They called to report an increased number of gastroenteritis presentations during the previous evening. We went on and interviewed 3 of those cases on Friday afternoon, but we were unable to identify any common exposures. So my question to you, hopefully that poll has launched, is based on this information from this initial phone call, do you think that this is an outbreak? The options are yes, no, or unsure. Ooh, and it looks like we have pretty even split. I'll just show the results. So 50% yes, 33% no, 17% unsure. I think at this stage, it's a bit early to tell. So any of those answers are appropriate. Okay, back to the scenario. There's been a bit of breaking news, and the same emergency department has just called back because there's been more gastroenteritis cases presenting overnight. And the nurse that rang said that several of these patients had reported eating pork or chicken rolls from a bakery in the area. So what do you think now? Do you think this is an outbreak now? And again, there's a poll there for you to pop down your quick response. Okay, and I can see that most of you now have jumped to saying that yes, this is an outbreak. And I guess the big difference here is that you've now got cases of an infectious disease potentially, because they've all got gastroenteritis, but it's actually now linked to a potential source, this particular outbreak, sorry, not outbreak, this particular bakery in the area. So the Public Health Unit has a meeting to go through these details and has decided that yes, this is a potential outbreak that we need to investigate. So now we move on to step 2, which is to plan that investigation and to form our outbreak investigation team. So typically most public health units will have an existing outbreak plan, which does explain how they will investigate these outbreaks. and also the roles and responsibilities. The team that I've got listed there with the outbreak coordinator, public health practitioners, environmental health officers, the epidemiologist, and an admin office is what we call our simple outbreak team. So for most outbreaks, you'll start off with a team that has these 5 roles in it. As the outbreak gets bigger, you'll add more and more people to each of those teams. Now, the outbreak investigation team is responsible, obviously, for managing the outbreak. Not every person involved in the outbreak needs to be on this team. They're kind of the overarching management group. They report regularly to, they meet regularly to report on actions, review any data that's come up, decide on next steps, and declare the outbreak over. So for the outbreak that we've just discussed or has just been detected through that emergency department, an outbreak investigation team was formed within that local public health unit. The team leader at this stage is the head of the enterics section, so the section that deals with foodborne illness. 2 public health officers, or PHOs, have been assigned, as has the AusFoodNet epidemiologist. AusFoodNet's a national group that has an epidemiologist in each jurisdiction to look after foodborne illness. There's also an environmental health officer, or EHO, assigned to the team. And they hold that initial meeting to plan their first steps. So what are the first steps once you've got your team together? Moving on to step 3, we now define, find, and count our cases. So it's a little bit of a threefer. In terms of defining our cases, we develop an outbreak case definition. Now, this is a set of criteria for deciding whether a person is an outbreak case or not. And this criteria should include the disease or health event, so whether they've got gastroenteritis or syphilis, whatever the disease might be, if it's laboratory confirmed or has a clinical definition. The additional information specific to the outbreak then includes your person, place, and time relevant to that particular outbreak. Once you've gone on and defined who you're going to count as an outbreak case, you then go out and find as many as possible. And we use active measures and passive measures to do so. So, for example, we might put an alert out to doctors for anyone that fits a case definition for them to be tested and reported. We might go and conduct screening if it's an outbreak in a set population. And there's a few other ways. We might go and do contact tracing or case follow-up. But the idea is to find as many cases as possible that fit our outbreak case definition. Once we've found them, we then count them. And I don't mean just numerically. We actually use an initial standard questionnaire to collect basic information on our cases. And things like your demographics, where they lived, onset dates, and anything sort of general about the cases. And we store these in a line list, which is pictured there at the bottom there, where you've got a case in each line and your variables in columns. We do that because it helps with our analysis later. Okay, so going back to our actual outbreak, the case definition was defined as a possible case was defined as an individual with diarrhea and either vomiting or fever with an illness onset after the 1st of January 2011 who attended a hospital ED or a GP practice in the local public health area. So you can see here that the disease of interest is diarrhea and either vomiting or fever. Our person is anyone an individual that fits that disease profile who attended a hospital, GP or ED. Our place is in the local public health unit and our time is after the 1st of January 2011. To find more cases, the public health unit requested daily reports from the 5 emergency departments closest to the bakery premises on anyone that fit that possible case definition. GPs in the local area and other public health units were also alerted to the outbreak and asked to report possible cases. They then, once they found those additional cases, interviewed them using a standardised questionnaire, which asked questions about their exposure to the bakery, the onset date, symptoms, date of exposure, and any foods consumed. Typically, once we've got this initial information and we've stored it in a line list, we will then move on to step 4, which is to do our descriptive epidemiology, which involves describing our cases by time, place, and person. or person, place, and time. So what's in a different order there? So we want to describe our outbreaks, so our outbreak cases, so that we know who we're dealing with. Often by doing this descriptive analysis, we can get clues about what's causing the outbreak, what the source might be, potential modes of transmission, and at-risk population. We may be able to come up with hypotheses, as I said, about the source of the outbreak, which then might help us control it by implementing control and prevention measures. And as I said before, we use our line list to do that analysis. So for our analysis by person, we're asking who is it that's getting sick, what age are they, what sex are they, etc. For place, we're asking where did they get sick, or often where were they living when they got sick, because we often only have residential information. And then with time, we're looking at when did they get sick, and that can actually help us a lot with figuring out modes of transmission and potential incubation periods. Okay, so doing our descriptive analysis on our gastro cases from our public health unit. This is a table that looks at sex, age group, and symptoms. And if you want to have a quick look and pop any findings that you may have in the chat, feel free to do so. Just give you a second or two to have a look at that table. Nobody's jumping in, so that's okay. I'll start. You can see with looking at sex, we've got 74% females, 25% males, suggesting that there are more females involved in this outbreak. With regards to our age group, you can see that most of the cases are in that 20 to 29 year age group, with the second highest being that 30 to 39 year age group. So we're looking at younger adults. And in terms of symptoms, everyone had to have diarrhea because that was part of the case definition, and most had vomiting and fever. With regards to where, all cases were from the local area of the public health unit, again, because that was the case definition, and most of the cases reported eating at that same bakery that was originally implicated. And then in terms of the when, this figure shows the epidemic curve. So it's a plot of the number of cases by the date of onset in blue and the date that they went to the bakery in grey. This is a classic, what we call a point source outbreak, because excluding that first case, most of the cases occurred around the same time, and there was an exponential increase in cases. This tells us that whatever's causing the outbreak occurred all at the same time to these cases. Okay, so once we've done our initial descriptive analysis and we know who it is that's getting sick, we then want to ask the question, well, why are they getting sick? What is it that's causing this outbreak? And we do this by generating, well, we do this to generate a hypothesis, and we have a couple of methods in which we attempt to do this. So the next step is to generate hypotheses, where we collect systematically as many exposures as we can from our cases during the period before they were sick. Some of the questions we might ask, again, depending on the disease, will be, what did you have for breakfast the day before you got sick? Did you eat any soft cheeses in the 4 days before you were ill? Did you travel anywhere before you got sick? We typically have two types of questionnaires for this step. Trawling questionnaires, which asks open-ended questions, and you get lots and lots of information from those open-ended questions. For example, what did you have for breakfast? What was the brand? Where did you purchase it from? What were the ingredients in your muesli? We get lots and lots of information. The other method that we use is what's called a shotgun questionnaire, where we have a predefined list of exposures and we ask for a yes or no response. So, did you eat soft cheeses in the 4 days before? Did you eat this? And if they answer yes, we collect that detailed information. There are pros and cons of both of these approaches. Trawling questionnaires, you get a lot of information, but it's all qualitative and can be difficult to compare. Shotgun questionnaires, easy to analyse because you've got your yes, no answer. But if what's causing the outbreak isn't in the list, you won't ask about it and you miss the source of the outbreak. Once you've done those questionnaires, you then have to take all of that information collected and tally up the reported exposures for every case. And you can see there an example of tallying up the number of cases that have eaten those food items there. You then need to make some kind of assessment as to whether the items that have the highest number of cases reported are unusual for this particular group of people. For example, you can see here that most people reported eating cake and pizza. When you think about the total population, would most people eat cake and pizza in a 4-day period? I'd like to say that I don't, but probably, definitely in the last 4 days, I've eaten cake and pizza. So it might just be as common in the general population as it is in your outbreak cases. So you need to kind of come up with some idea as whether or not what you're seeing in cases is unusual or higher than what you expect. And you can do that by comparing this data to previous outbreaks, by looking at food frequency surveys that you might have access to, or again, just by doing a quick look around the room of your outbreak investigation team. Your outcome of this step is a short list of the potential exposures that you then want to test in the next step. So going back to our outbreak, they did collect detailed food history, so the trawling questionnaires for the 3 days before illness from the first 26 cases. And the questionnaire they used is pictured here. It's a standard 3-day food questionnaire. Of these cases, 81% reported eating goods from the same bakery. When they did a quick survey around the room of the outbreak investigation team, only one had ever eaten it before, and that was several months ago. So it was quite unusual that so many people had eaten at this bakery. So the leading hypothesis was that the outbreak was caused by contaminated food items from that bakery. Now, just because your hypothesis generation process came up with a hypothesis doesn't mean that that is actually the cause of the outbreak, and you need to go on and test that hypothesis using epidemiological methods. And the aim of doing these ethnic studies or analytical studies is to test your hypothesis by comparing the exposures, what they ate, where they travelled, etc., between your outbreak cases and a group of people who are not outbreak cases. And we typically use 2 different studies to do. The first is the cohort study, and this is usually done when our outbreak group or our outbreak cases are part of a defined group. For example, they all attended the same function. They all went to the same camp. Everybody that was at the event had the same opportunity to be exposed. And when we do a cohort study, we calculate the relative risk. We compare the proportion that are ill in those that are exposed with the proportion that are ill in those that are not exposed. It's a little bit different to a research cohort study because of the exposure and the disease is ready to go from the start, but we do calculate the relative risk. The second type of study we do is a case control study, and we use these mostly when we don't have a big cohort, or the cohort is so large it's not practical to everybody. Or you've got cases widespread, but an increase of cases throughout New South Wales. You're not going to interview the entire population of New South Wales, so a case control study is more appropriate. And here, because we don't have that full population, we have to actually calculate probabilities or odds. So we use the odds ratio, and we compare the probability of a case being exposed with the probability of controls being exposed. Now, thinking back to our outbreak of cases picked up from a couple of different emergency departments, they've all eaten at a bakery, but we don't quite know when. What type of study or what type of analytical study would you suggest doing for our outbreak at linked to the bakery? Do you think a cohort study would be more appropriate or a case control study? I'll let you pop your initial thoughts. All right, so it looks like, I'll share the results. Most thought that the case control study would be more appropriate. A couple thought the cohort would. Because of the way that we found out about this study, about this outbreak, in that it was people from the community that we then later linked back to the bakery, the cohort, it's not a cohort. or if it is, we would have to include everybody in the public health unit. So it's not a defined group. It's not a group of people that went to the bakery and then got sick afterwards. It's a random sample of people from the community that we bring to the bakery. So the case control study is the most appropriate study type to do, which is what they did. The case control study was done between the cases already identified, and cases were asked to nominate friends or family that had also eaten at the bakery as controls. Now, I am just going to let you know that the data I've got here, I made up because I didn't actually do an analytical study in the real outbreak, but they did identify certain foods from the outbreak. So the intention is right, but the data is actually fabricated. So looking at this data, and you can see we've got a group of cases and a group of controls, the number that were exposed and unexposed, and our odds ratio, which shows the relationship between the odds of cases being exposed against the odds of controls being exposed. Any guesses on what you might think is the cause or the source of this particular outbreak, given the data in front of you? And for those of you that have any experience in looking at epi studies. Okay. Of those that have answered, you've all answered that it is the pork rolls, which is the running hypothesis because it does have the highest odds ratio. And the way that we would interpret that odds ratio of 5.2 is that the odds of cases being exposed, the odds of cases eating pork rolls or consuming pork rolls, is 5 times higher than the odds of controls eating pork rolls, which does suggest that being a case is associated with eating pork rolls. The chicken rolls also have an elevated odds ratio, so they may also be a potential source, or people that ate pork rolls also ate chicken rolls. But there's definitely something going on with the pork and chicken rolls. Okay, that's our epi study. Now, while the epi study is going on, our environmental health officers and our laboratory staff are also doing their own investigation. So this usually happens concurrently, and the idea behind these is also to try and figure out what the source is. So in our environmental investigation, the environmental health officers are trying to figure out how and why the pathogen got into the environment and then how it spread to cause the outbreak. So here we're looking for contributing factors. How did the pathogen get into the environment? So how did the salmonella, for example, get into the chicken? And we look at the initial contamination, any mechanisms that meant that the pathogen was able to survive and proliferate. The other component is looking at environmental antecedents. So why did the contributing factors occur? And I often think about this as the human components. So we look at people, processes, equipment, and economics. Were people trained in appropriate food safety measures? Was the proper hygiene done? Were they cross-cutting because they were trying to save money? And we conduct our environmental investigations at the setting where the outbreak occurred. This might be a restaurant, a supermarket, processor, or a farm if it's a foodborne outbreak. It could be a childcare centre, a hospital, pool, cooling towers. There's a lot of different settings that outbreaks can occur depending on the disease. We also often try and trace back the food and do sampling of products and the environment. So with regards to our outbreak, they did go and do an inspection of the premises the day the outbreak was originally notified. And what they did was look at the food handling, cleaning practices and cooking methods. They observed the workers doing that. They took swabs of the environment, so chopping boards, benches, refrigerators where the food was stored, and they also took food samples. They then looked at some of the more suspect foods and tried to figure out where it came from. And they quickly realised that raw eggs were being used in the mayonnaise put on the chicken and pork rolls, which is quite a red flag for gastro outbreaks. Now, they summarised their investigation, the results of their environmental investigation in the table that you can see up there now, and they actually then linked all of the breaches that they found against the food standard codes that they were breaching, or the component of the food standard code they were breaching. You can take a quick scan of that look and you can see that there was lots going on in that outbreak, in that bakery that suggested why the outbreak occurred. So you've got inadequate temperature monitoring, no doors on the chilled food display, so no temperature control. Eggs were stored at room temperature, allowing contamination to proliferate. Food equipment not cleaned properly. My favourite, the food mixer whisks were stored on the floor. Inadequate washing facilities and poor hygiene by the staff. So lots of things going on there at the bakery that explains why an outbreak could have occurred, how contamination or proliferation of a pathogen may have occurred with the temperature monitoring and environmental antecedents, or issues with hand washing, hygiene practices, and food safety being breached there at the restaurant, at the bakery. Okay, the third investigation that we do during an outbreak is our laboratory investigation. And this is typically done at public health laboratories, and they have two roles. They do confirmatory testing of diagnosis, and then they also test all of the samples collected during the outbreak investigation and try to link the human specimens, the food specimens, and the environmental samples to the one source. There's quite a few different tests that are done in a laboratory that can be done at the laboratory, either phenotypic based on function and traits. I think of this as hair colour, eye colour, and then more often genotypic analysis. So we're all quite familiar with PCR and whole genome sequencing now, and there's a few other methods that we use. Whole genome sequencing has become the gold standard and is sort of most often used. With these sort of genotypic analyses, we do tend to get these trees that will show us the relatedness between our specimens. But for the outbreak we're investigating, it did occur back in 2011. So they were using a technique there called MLVA, where they run a gel through the samples and come up with these lines. And where the lines are sort of show if the samples are similar. So when they did this for the specimens collected in this outbreak, they found the outbreak strain was Salmonella typhimurium, with an MLVA type of this 3-10-8-9-523. And that strain was found in 47 of the human specimens, 62% of the food samples collected from the bakery, and 45% of the environmental samples also collected from the bakery. We tend to call this the trifecta of laboratory evidence because they were able to link human, food, and environmental samples because they all had the same MLVA type, and this is very suggestive that the outbreak source was food served at that bakery, as well as the high proportion of environmental samples suggests that there was quite a bit of cross-contamination going on at the bakery as well, which we saw from the results of the environmental investigation. So those three types of investigations, your epi, environmental, and laboratory, for this outbreak were all pointing to the one source. This brings us to step 8, which is implementing control and prevention measures. This is the main purpose of the outbreak investigation. You want to figure out what's going on so you can stop it. It is down as step 8, but really should be considered the 4 stages of investigation. You can implement control and prevention measures right at the beginning of the outbreak based on what you know about the potential pathogens, the probable sources, and the probable modes of transmission. For some outbreaks, though, you do need to figure out what's going on before you can implement control measures. They're typically aimed at 3 areas: the outbreak source, by either stopping it or removing it. If it's the other one is suspected vehicle or transmission, if you know what the route of transmission is, or by preventing susceptible humans from coming into contact with the source. For this particular outbreak, they knew the source was the bakery, so New South Wales Food Authority served a prohibition order on that bakery and closed it until they met the conditions listed there. So all of their equipment had to be cleaned and sanitised. Their fixtures and fittings had to be verified free from salmonella, and they did go in and retest a couple of times. And the food handlers had to show that they had completed a food safety and hygiene course. The business itself agreed to permanently cease production of raw egg butter once they realised that that was the source of, or the potential source of this particular outbreak. Okay, step 9 is also another one that you do the whole way through the outbreak, not just when you get to it in the order of steps, and that is to communicate your findings. And we typically communicate our findings with several different groups. Within our investigation team, we will have regular meetings. We will contact each other outside these meetings, and we will keep a running situation report or SIGREP, which has all the details about the outbreak and it's added to as you move through the investigation. We also often need to communicate with the general public and or the affected community. And this is mostly to communicate with them what's going on so that they can make informed decisions about how to reduce their exposure to a potential outbreak or what to do if they are an outbreak case. And you might recognise Dr. Jeremy Baccanotti there from New South Wales Health, who often gets in front of the camera to deliver these messages to the general public affected community. We often also need to communicate with the media to get those messages out to the general public. And we can use the media quite successfully to help us with case finding, to inform the public about outbreaks and what they can do to prevent themselves from becoming an outbreak case, and to minimise any conflicting information, to make sure that we're the ones that are providing information about the outbreak. We may also need to communicate with other organisations within our jurisdiction, nationally and internationally. And there are a few reporting requirements through both national legislation and international legislation that we need to abide by with our outbreaks. This is a media release that was put out, not for the outbreak that we've been looking at because it's quite old and the press releases are not available. This is a more recent one, and it's a press release basically saying that an outbreak is going on. New South Wales Health and New South Wales Food Authority are continuing to investigate, and that the public health officials are aiming to speak to everyone that has attended this particular conference that was linked to this outbreak. So New South Wales Health is working closely with the Food Authority to investigate the cause of the outbreak. So at the beginning of the outbreak, just putting it out there that an outbreak is detected and they are. This then brings us to step 10, which is when we get to declare an outbreak over. And we typically do that when the number of cases returns to what is normally expected. Or there's been 2 incubation periods, the time between the symptoms of the last case. But for those diseases that are monitored through surveillance, this is quite easy to monitor. We can just look at our surveillance data and see when the cases stop. We can continue to monitor in case cases start again and keep a watching brief. The actions that we need to take at the end of an outbreak is to write a final report. Now, this might just be an update of the SIGREP, or you might want to write it up for publication in the peer journal or an internal report that's circulated at the public health unit. The other action that is recommended after all outbreaks is to conduct an after-action review or debrief. This might be a chat amongst those that were involved in the outbreak or a full large-scale after-action review to work through what worked well, what could have been better done next time, and if there's any recommendations to help for future outbreaks. It is recommended that these are run as a facilitated discussion, run by someone who is not in the investigation. And there's lots of literature on how to do these after-action reviews. In terms of sort of the summary of the outbreak that we've been going through, there were 83 cases identified, of which 58 were interviewed, and all of those roles from that single bakery. As I mentioned earlier, the same MLVA type was identified in human, food and environmental samples, providing that strong evidence that it was a food item at that bakery that cause this outbreak. The business did produce raw egg butter, and they didn't have any pathogen step. They also mixed ready-to-eat foods with existing batches, and as I showed in that table, there was lots of evidence of cross-contamination. There was also a clear lack of food safety knowledge and multiple breaches to the food standard code. And although they couldn't quite pinpoint one exact food as the source of this outbreak, nor how the salmonella got into the bakery, the control measures that they implemented, shutting the bakery and doing a full clean, did stop further cases. And if you're interested, I have included a link to the article that describes that outbreak that occurred in Sydney back in 2011. So that brings me to the end of the 10 steps, and I've just popped them up there for you to have a look through again. There are a couple of different versions of the 10 steps. These are the ones that we use to teach our outbreak management unit. So what next? Just to let you know of some of our short courses coming up. So as Peter mentioned at the beginning, I teach both outbreak management and public health surveillance. Both are semester-long units, but we also teach both as a 4-day short course, which you can come and do and then complete the assessment and get credit for those. So we do have our public health surveillance short course occurring in Melbourne in August, and an outbreak management short course to be online in semester 2 and students can those dates. If you're interested, you can have a look at that link to see what they cover and when they're going to be held. And just a quote from a recent participant of the outbreak management course. So happy to come back to you, Peter, for any questions or comments. And I've also included our health protection email address and my own email address there. Thank you very much.
Thank you very much, Michelle. Unfortunately, the chat function is not working at the moment, so everything needs to go into the question and answers mode. Thank you for your presentation. That I did not realize how many steps there were in the process in an outbreak. So it was really great to hear that. So I'll open it for questions. Are there any questions for Michelle?